Hello dear students, I am Dr. Ashish and I am the faculty of Physiology. Now first of all, best of luck for the exam, okay, that is your NEET PG, might be the last NEET PG, okay, on 18th of April, okay, and my only advice to you is what? They would be most likely long clinical questions, okay, cases. So we are expecting long clinical cases, okay, and in which they will give you what? Images, okay, then also path slides, histopath, okay, also X-ray, CT, ultrasound, or even the signs, okay. So they might give you all the like Trousseau sign, or they might give you all this acoustic sign. So they will be giving lots, and then yes, the question, okay. So therefore even the anatomy physiology question would be most likely clinical case, because if they are giving 200 MCQs, that means they are going to give long question. Otherwise if they give one liner, 200 one liner, that will just finish the paper very fast, okay. So that is most likely expectation. So my advice number one is first, don't get afraid, more images, patho, X-ray plus lab findings, they actually will give you more clues. So more clues, so rather than get confusion, it can help you solve the question much better. Number two, read options first for very long questions. So your brain will already be in a zone that what they are actually asking. Let's say you read the options, okay, and you read the options and you know that in the option they are asking what? They are asking what the diagnosis, or they say which of these is causing, like Cohen's, Edison, Cushing. So you already know that they are asking something about the adrenal gland disorder. So now your mind should be okay, sodium increase, decrease, the level of glucose, all this, and now you are able to find the question by all this feature they are giving, like Cushing's. You might be having this lemon stick appearance. So that's why read the options and then read the question. So now you will read the question. So that will give you a much better idea about solving the questions. Are you clear now? Fine. Okay. And number three, don't rush into the question. Try to see the question as per the merit. So that's why options will give you a much better idea. So most likely this is what I will just advise you, okay. And last 10 days you just go through what most important. So my advice number three, for last 10 days, because today I think not 8 or 7 days. So what do you do? Advise last 7 days, see all important investigations, okay, then findings, like all this, okay, Cullen sign or the backstride, okay, and also the treatments. So they should be at your fingertips. So treatment of various conditions, like maybe the Parkinson. So what do you give? L-Dopa, or we'll give this Ropinirole, Pramipixole. So all these things should be at your fingertips, okay. So these are my suggestions to you, okay. And please, images are very important. So go through images also. So don't try to read whole theory. See the important images. So important images and all important investigation, findings and treatments, okay, that will be more than sufficient for you, okay. So let's come back. So I'm discussing clinical questions from the physiology. So look at this question. They're asking atrial rate is 80 beats per minute, and atrial rate is nothing but SA node. So it's the SA node which give 80 and third degree block. So obviously what happens, the impulse cannot reach the ventricle. So now what happens, a pacemaker site located will trigger ventricle. So now what happens, the bundle of His become the new pacemaker. So in third degree, bundle of His become the new pacemaker for the which structure for our, right. So bundle of His is the pacemaker for ventricles. So who's the new pacemaker? Bundle of His is the new pacemaker, okay. Now the rate is 40. Why? Because the bundle of His has a rate of 40 to 60 per minute. We know that, and this is what is a part of Stokes-Adams syndrome. Stokes-Adams syndrome with the pacemaker change. So now first question, 1 P for QRS not possible. Why? Because now the P wave would be coming at the rate of 80 and the QRS is 40. So it will be almost 2:1 ratio, not true. Invert T. Invert T is mainly seen in ischemia. It's a feature of what? Ischemia, myocardial ischemia. And there's no ischemia, so there's no point of inversion. So again, not true. Then shortened PR, there's no PR interval. Why? Because P and QRS are independently acting. There's no PR. There's no. Normal QRS, yes. Why? Because the bundle of phase is giving the current, the bundle branch is normal, so that's why this is normal QRS with P wave coming at any time. So D is the best answer. You will have a normal QRS in this case, okay, normal. So QRS is broad in two conditions, remember that. So if you get a wide QRS and decrease heart rate, most likely suspect bundle branch block. And if you again get a wide QRS with an increased heart rate, then suspect ventricular tachycardia, okay. So there's a very simple logic. If you get wide QRS, if you get a wide QRS and there's a low heart rate, suspect bundle branch block, and maybe it causes slurring also, may cause notching also, notching. That is the MNW pattern. So notching, wide QRS and decrease heart rate, bundle branch block. If there's a wide QRS, increase heart rate, that is VT, okay, that is VT, okay. In case of other condition, the QRS remain normal. So answer should be D. A normal QRS complex is there, okay. Now we see the next question. A 45-year-old male inhale as much air possible and then expire with maximum effort. So this is called as vital capacity, okay. So remember, maximum inspiration then maximum expiration gives vital capacity, gives vital capacity. So let's calculate. So he is at this point, he is at maximum inspiration. This is the max inspiration. Now as he expire, this is the flow rate. It's called as PEFR, peak expiratory flow rate. Then the flow rate decrease. This is MEFR, mid expiratory flow rate, and here it is the end of expiration. End of expiration. So what are the air coming? If I take this point as roughly 5.5, 5.5, this is 1. So it is 5.5 minus 1, that is 4.5. So 4.5 liter must be the vital capacity in this patient, okay. So you can calculate the VC is what? It is 4.5, okay. So that will 4.5. And remember 2-3 things. If there is an obstructive disease, what happens? You will get a graph like this, okay. So I'll use a different color. So if you get a graph like this, it indicates what? OLD, obstructive lung disease. So in obstructive disease, the flow rate decrease, so graph will become flattened, okay. So if you get a flattened graph or decreased graph like all these, they indicate obstructive disease. What happens? There is a decreased flow rate, decreased flow rate. So PFR, MEFR decrease in the obstructive disease, and in restriction the width will decrease. In restriction the width will decrease. Flow rate is not affected much, but the width is going to decrease. So if it is restrictive, it will be like this. So this is RLD, restrictive lung disease. So a narrow curve is restrictive, a width is normal, but the height is less, that is a restrictive. So what happens? Low VC. Restriction, what happens? Low VC. So if you get a normal curve, this would be a OLD curve, this would be a RLD curve, okay. So this is RLD, this would be OLD, and this one is normal, okay. So this will be the answer in this question, okay. Now we see the next question, that is a 28-year-old woman is brought in emergency confused state and locked in the room for past 2 days, not eaten or drunk. That means there must be most likely dehydration because not taken the fluid intake. BP is less, okay, that is almost shock level BP. Heart rate is increased, which again indicates shock. Rate is normal, respiration is normal, okay. So most likely we are thinking is having some kind of hypotension or let's say shock, okay. So what happens in shock is there is compensatory mechanism. So there is compensation by one is sympathetic, increased sympathetic baroreceptor, which cause increased heart rate. That is why in shock heart rate will increase, and two things occur. If there is an increased heart rate, it will prevent decrease in the BP. So compensated and uncompensated shock is basically given by the logic. If BP is maintained, it is compensated, and if it start to fall, it is uncompensated. Number 2, RAS is trigger, increase RAS, and RAS increase ADH also and aldosterone. So increase angiotensin 2, aldosterone and ADH. Now what does the ADH will do? So ADH is going to do what? It will cause two things. One is vasoconstriction and increase water absorption. So it causes increased water reabsorption at P cells in collecting duct. So first V1 is for vasoconstriction via V2 receptors. V1 is for vasoconstriction. So V1 is for vasoconstriction. So V1 is for which function? Vasoconstriction. Okay. So V1 cause what? Vasoconstriction. Then V2 cause of water absorption. V3 is in ACTH. V3 is ACTH. So obviously V3 is wrong because it is in pituitary, not in the blood vessels. V2, it is true. V2 blood vessel, no, it is in the collecting duct. And V1 heart, no, it is in blood vessel. So answer would be A, increase V2 receptors on the collecting tubule. Increase V2 receptors on the collecting tubules. Okay. Next question. A 32-year-old man was brought to emergency room with road traffic accident. Again, there is a shock, and most likely it's a hypovolemic hemorrhagic shock. So hemorrhagic shock, the pulse is increased. He is having obviously fracture, so yellow, he is in code yellow. Okay, not this. Okay, now what happens? So obviously in shock, again there is compensation, so venous rhythm will increase. How can it increase? If it increase, there would be what? There would be normal cardiac output, so it is decreased. So it's not true, it is decreased. Resistance will increase? Yes, true, increase. Why? Because sympathetic cause vasoconstriction, and that's why skin become cold and the kidneys make less urine, and that cause skin become cold, clammy skin. Okay, GFR increase? No, kidneys are getting less, so decrease GFR. A and B correct, not possible. So and decrease venous return. Why? Because of loss of blood. So that is why JVP will decrease. Okay, so JVP decreases, so decrease JVP because of decrease venous return. So only thing right is yes, peripheral resistance will increase because of what? Vasoconstriction in this patient. So a vasoconstriction is going to increase the circulation. How? It will prevent the excess blood from going to the skin, muscles, GIT, and preserve the blood flowing to the brain and the coronary circulation. So that is why the best answer would be yes, venous return will decrease, not increase. Peripheral will increase because of vasoconstriction, it increase the peripheral resistance, and that's why the skin is cold, GFR decrease JVP. Okay. Fourth question. A 40-year-old male patient is not able to recognize object held in hand after injury. So now recognize. This is called as stereognosis. Stereognosis. That is identify by touch, not by seeing. Identify by touch. Identify by touch. So what is stereognosis? Identify an object by touching the object. Okay. So what is the idea? So understand. First, lateral spinothalamic tract. Lateral spinal. It's basically for pain and temperature. Pain and which I told you, lateral lath. If someone kick you, lath mara, you will feel pain and you become hot with anger. So remember, lateral is lath mara. That is pain and temperature. Then come dorsal. So what is the funda about the dorsal? I'll discuss, but few that the medial. There is no medial tract. It is anterior. So anterior spinothalamic tract, STT. Ant. When an ant is walking on your skin, see this ant. So if an ant is walking, what the ant will do? It will cause itching, and it cause itching. So you want to, so remember, ant cause itching. Chi. Ant is chi cause itching. So it cause itching. So it carry itching. And ant is running here and there. That is crude sensation. So it cause itching and crude touch pressure. Crude touch and pressure. So itching, crude touch pressure is by the which one? It is by the which one? It is by our lateral. Spinothalamic is pain, temperature. Anterior is itching and crude touch pressure. Okay. Now rest all are by dorsal column. So rest all by dorsal column. Rest all sensations. Rest all sensations are carried by what structure or what thing? It is by our which one? It is by our dorsal column. So what will dorsal column carry? So let's have a look. So dorsal column is going to carry the following sensations. Let's see. So let's see. So are carried by dorsal column. Dorsal column like touch, pressure, vibration, stereognosis, graphesthesia, all are by this column. Graphesthesia or this stereognosis. So all are by which thing? The dorsal column. So dorsal column is responsible for all these sensations. Are you clear? So dorsal column. Okay. So what is the answer here? So obviously the answer would be dorsal column A. So A carry the touch sensation. Okay. Now we see question number 6, which waves are seen. Now first is how do you identify the waves? So I'll teach you very simple logic. Understand, EEG waves are identified on which basis? Frequency basis. So which basis? Frequency basis. How do you identify? The answer is we identify on the basis of frequency. So what basis? Frequency basis. Okay, fine. So how? Let me explain. First is understand number of waves per second give you frequency in hertz. Okay, so it give you the frequency in what units? Hertz. Okay, that is number of waves per second give you frequency in hertz. Okay, now understand. Okay, when you are awake there are two states. You are doing nothing and you are relaxing, you are relaxed, relaxed mind, or you have an active working mind, active working mind. Okay, so either you are doing nothing, you have which mind? Relaxed mind, or you have a active working mind. If there is a relaxed mind, we get alpha wave. If active working, we get a beta wave. Okay, alpha wave is also seen when the eyes are closed and the person is not doing any activity. So eyes closed, no activity, then no stimulation. So eyes are closed, there is no stimulation. Okay, and no disturbance. So all this give alpha wave, and this is what eye opening or what stimulation of brain or sensory stimulation, then what? Active thinking mind. So active thinking working mind. So that is the case. So what is the frequency of beta? It is 8 to 13 hertz, and alpha is how much? It is approximately, it is, sorry, made a mistake, this is alpha 8 to 30, it is 14 to 30 hertz, 14 to 30 hertz. Okay, now when you're sleeping you get two kind of waves in the sleep. So what are the waves we see in the sleep? So let's see. In sleep we have the following waves. Sleep, either we have the theta waves, deep sleep, or light sleep. Now deep sleep you get delta waves, light sleep we get theta waves. So get the theta wave. So how to identify? Understand, delta, deep delta, dada, deep delta, light ta, theta, tata. So remember, light theta wave and deep delta. So when you are in deep sleep you have the delta wave, frequency 0 to 3 hertz, and theta is light, that is 4 to 7 hertz. So remember, 4 to 7 is theta, 0 to 3 is delta, 8 to 13 is alpha, and more than 13, that is 14, 15 are all beta waves. So let's see the frequencies now. So in this graph you have to first draw a line, and this line will explain what are the funda. Let's say not working well, so I'll make it myself. Difficult to draw. So make lines like this. Okay, now count the number of waves. Here these are noise, so this is noise, so you can ignore this noise, focus only on this. So there are almost 2 waves, so 2 waves we can say. Here 1 wave, 2 wave, 3 wave, 4, 5, 6, 7, 8, 8 waves, or maybe 7 or 8. So 8 is most likely answer. So 8 in 1 second, so 8 hertz, and this is 2 hertz. So we know 8 is most likely alpha and 2 is delta. So what is the answer? It is alpha and delta. Alpha and delta. B is the best answer. Alpha and delta. Okay, fine. Now we see next question. A 35-year-old female was watching TV for long hours with hand under the head. Must be watching some Indian Hindi serial, okay. And now as she is watching TV like this, okay, it causes what? I might have fallen. It causes what? It causes, yes, compression of the nerves, okay. So now most likely there is a compression. So there is a what? So pressure cause nerve compression. And this cause a conduction block. This cause a conduction block. So what do we get here? We get the conduction block, okay. Now this conduction block is called as neuropraxia. Neuropraxia, okay. So what is it called as? It is called as the neuropraxias, okay. So this neuropraxia is a very common feature. In which condition? In the case of patient who are having any kind of what? Yes, problem in the case of what? Nerve fiber, and it's a temporary one, okay. It's not permanent, it's temporary. It's temporary. Now remember, the bigger fiber have bigger diameter, so they get more pressure, they get compressed more. So remember, A is the thickest and it's basically sensory motor. Sensory motor. Whereas B is thin and it is autonomic fiber. Autonomic, preganglionic. Preganglionic. C is thinnest. Again autonomic but post-ganglionic. Post-ganglionic. So it is thinnest and post-ganglionic. So it is thinnest and post-ganglionic. Are you clear? So it's thinnest and post-ganglionic. Also slow pain and temperature. So what is for fast pain? Sensory motor, it is A. So now what happens when you apply the pressure, the A fiber is the thickest, so it gets compressed more. Why? Let me show. Let's say there are 3 fibers, A, B, C. A, B, C, and this is nerve. So this is a nerve. So when there is a pressure, obviously what the pressure will do? It will make the fibers like this. So as it come closer, obviously A would be compressed. B are relatively spared. So that is why A would be compressed the most. Then B, then C. So that is why A is affected more than B and B more than C. Least affected is C. And C we know can cause pain. So that is why the person will have loss of motor and the touch. And that's why he can feel this tingling sensation, muscle weakness. But pain can still be there. So pain is there. Tingling is there, numbness is there, all are feature of what? All are feature of what? Compression of the nerve fibers, okay. So that's why what will be the right answer? So it is going to what? This is weakness, that is motor fiber. Weakness is, tingling is again sensory. So obviously it's not sympathetic because that is B fiber. B is not affected much. It is either A or C. C is, yes, spared. A is affected. So it is the right answer, A. So A fibers are responsible for her this condition. Are you clear? So A fibers, okay. Now we see question number 8. Which of the following movement is seen in this case? Okay, so these are the option 4. Contraction, peristalsis, segmentation, pendular. Now first understand Contraction is non-specific. So it is all movements are non-specific. All are contractions. Then segmentation is only causing mixing and churning of food. It causes mixing and churning. It is what? One by one. Contract, relax, contract, relax, contract. It's like what you are making this dough from the flour by adding water. You are making what? The dough. So it is mixing and churning movements. Churning of food. Peristalsis, it actually moves the food bolus further. So it causes a movement, and pendulum is to and fro. It is not seen much, so it is to and fro, and that is not seen in GIT. You don't go and come back. It's not possible. It's either going forward or getting mixing and churning, but you don't come and go. So pendulum is not a feature of GIT. You can ignore. Okay. So what are the answer? It could be either peristalsis, segmentation. So let's see this. Okay. So discuss peristalsis, how it occurs. So in peristalsis, what happens? Let's say is a GIT. This is a food bolus. This is a bolus of food. Bolus. Okay. Now what happens is in the front and back we have two different things taking place. In the front we have we have ANO and VIP front. That's why it's called as anterograde. Anterograde. So what do we have? Anterograde, ANO and VIP. They both cause relaxation. They cause relaxation. And back side we have 5-HT acetylcholine substance B, which cause relaxation, contraction, sorry, it cause contraction. So that's why what happens in GIT is at the back and there is contraction and front end there is relaxation. So therefore the food is pushed forward. So that is why it will push the food bolus forward because of pressure from the back side. So it causes push bolus forward. So clear? So we'll push the bolus forwards. Push the bolus forwards. Okay. Done? So now let's see this diagram. So we can see that this is going further. So it was here, now it has come here. So obviously it's a movement. So it's a movement, and this movement is basically this substance moving. So that is why it's most likely a peristalsis. It could have been a mass movement, but that is feces, and that is done in colon, and that is not the right answer here. So most likely it is peristalsis because that is moving. So you are doing what? See, contraction at this end, and you are relaxing this end. So that's why there's a contraction this end, relax, and that's why the food bolus is going further. So you contract behind, relax in front. Okay. So 8 is peristalsis. Long question. Which of the following is characteristics when there is high BP? So there is a high BP, hypertension is there, muscle weakness is there, polydipsia, increased sodium, aldosterone, and plasma aldosterone renin. So most likely it is simple concept. There is an increase in aldosterone. So this aldosterone is increased. This aldosterone then increase the sodium. This increased sodium cause hypertension. Also cause polyuria because of increased sodium. There is a more loss. This polydipsia because of high osmolality. So drink more water. Okay. And aldosterone will decrease the potassium, and that causes muscle weakness or this. So decreased potassium cause muscle weakness. So decreased potassium will cause the muscle weakness in this case. So it causes a muscle weakness. Are you clear? So muscle weakness occur, and also aldosterone inhibit renin. So renin increase the aldosterone, but aldosterone decrease renin. So that's why a ratio of aldosterone renin give a idea about what? The syndrome. And this is basically what? The Cohen's syndrome. So this is the Cohen's syndrome. So Cohen's disease is when pituitary is involved, and here we are basically having the most likely adult because renin level is decreased. So it's Cohen's syndrome. Okay, fine. Diabetes cannot be true. Why? Because there is no in diabetes. Yeah, it could be, but again the aldosterone, sodium, all are increased. So that suspect what? Diabetes. Okay, clear. There is no hyperglycemia. There is no feature of this weight loss. Cushing, there is what? In Cushing there is increase in the glucocorticoid, which again cause high sodium, high BP, but aldosterone levels are normal. So again not the Cushing. Addison, there is decreased aldosterone. So it cannot be true. Decreased aldosterone. So not true. So answer is Cushing's syndrome. Answer is Cushing's syndrome. Okay. And with the treatment of this condition, obviously you have to block the aldosterone. So treatment is spironolactone. So the treatment we give spironolactone. So treatment is spironolactone is the treatment. Spironolactone is the treatment of this condition. Okay. Now in GDD, glucose is given orally, not IV, because. So let's solve this question now. So first is understand, when you give oral, there is, so oral glucose which is around 75 grams cause increase GIT hormones like CCK, GLP-1, GIP, gastrin, secretin, amylin. Now they all do what? First they all increase insulin. They all increase insulin, and as they increase insulin, it cause much better glucose redistribution. So that will then, yes, cause the glucose to be metabolized. So it help in managing blood glucose levels. So what it will do is, it will shift glucose from blood to the cell, thereby causing, so what? Shift glucose from blood to cells. So that is why hypoglycemia occurs. So that is why it will cause hypoglycemia. It will cause what thing? It will cause the hypoglycemia. So why? Because of shift. So that's why if you give just IV, and this causes which effect? Incretin effect. So they are incretin effect. Incretin. And which are the main? GLP and GIP. That's why we have drugs which act like this exenatide or DPP-4 inhibitors. These drugs, like all this gliptin, sitagliptin, linagliptin, okay, all this vildagliptin, they are going to increase the insulin via the effect of the GLP-1 and GIP. Okay, so that is why IV glucose will cause less insulin, causes less insulin. IV causes less what? Less insulin, and that cause a poor response. And that is why the hyperglycemia will persist for longer time and cause a poor glucose tolerance test result. Okay, so that is why if you give IV, it will cause less insulin release, and that cause a poor response. Are you clear? So what do we prefer? We prefer which glucose? We prefer, yes, we prefer which glucose? We will prefer this. Okay, so first, increase insulin, yes, true. Slower absorption, true, but not the answer. Why? Because it is true, but if that is the case, the glycemic rise will be much slower. So it's not true, but not the answer. Then rapid metabolism, no, it's true, false. Why? Because metabolism require insulin, and insulin is released more in oral case. That is why glucose level decrease much better in oral rather than IV. So wrong. All cannot be true because this is wrong. So answer would become, yes, 10. That is increase insulin release is seen where? In oral administration. Okay, so that is the case. So with this we'll finish this session. Okay, if any doubt you can just ask me. Okay, this is my Telegram number. So I use Telegram nowadays more because of time issues. If you're not using, you can SMS also or WhatsApp. My name is Dr. Ashish. Number is 9899529468. So 9899529468. It is the number.